A very warm welcome to all of you for this inaugural expert webinar series of the Ceylon College of Physicians in association with the Sri Lanka College of Endocrinologists. I am Manilka Sumanathilaka, consultant endocrinologist at the National Hospital of Sri Lanka. Today, we'll be discussing a very interesting endocrine topic, diagnosis and management of Cushing's syndrome. For that, we have invited a world authority in the area in Cushing's, Professor Ashley B. Grossman. He is the Emeritus Professor of Endocrinology at the University of Oxford, Senior Research Fellow at the Green Templeton College, Consultant Neuroendocrine Tumor Endocrinologist at the Royal Free Hospital, and Professor of Neuroendocrinology at the Bath and the London School of Medicine. Among his many achievements, he was admitted as a Fellow of the Academy of Medical Sciences in 1999, and he has written hundreds of papers, over 500 peer-reviewed papers and 370 chapters and reviews in mostly on hypothalamo-pituitary disorders and in neuroendocrinology. He has been heading many societies, including the European Society for Endocrinology and the Society for Endocrinology in UK, 2012 to 2014, and the chairman of the UK NETS Society, 2010 to 2012, and president of the Pituitary Society on 2015 to 16. His achievements are many, and this is not the time to go through all of that. A very warm welcome to Professor Ashley Grossman, first of all, for accepting our invitation this evening and for, as always, being more than willing to be of help for the Sri Lankan trainees and the audience. Without further ado, it's my pleasure to invite Professor Ashley Grossman to start his presentation on diagnosis and management of Cushing's syndrome. Over to you, Professor Grossman.
Manilka, thank you. Thank you very much. Are you all able to hear me now?
Yes.
Yes. Good, lovely. Well, this is a great honor and thank you so much. Unfortunately, I can't actually be with you in person, maybe sometime again in the future, but thank you very much. I think without more ado, I will go straight on. So if we can get to my slide presentation. And now we'll just take one moment. Great, okay. So I'm going to talk to you today about, I think, one of the most interesting of all endocrine disorders, Cushing's syndrome, both in terms of its diagnosis and therapy. And I'm going to talk about how you diagnose it, how you localize the source, one or two slides on the treatment protocols, how you might screen and if it's worthwhile screening, and then come up with a few conclusions. So although this may seem a rather recherche, a rather erudite topic and not much relevance to the general physician, I think you will see that it is worth diagnosing, and essentially, although it often seems complex, there are some very simple rules to follow in diagnosis and treatment. First of all, I think this is probably one of the most important slides. This is the way the algorithm works. You first look at the clinical symptoms and signs and suspect the syndrome. You then confirm the syndrome, then you localize the source. And if you go in any other way, looking at blood tests or looking at imaging, I think you'll go astray. So we always have to suspect this clinically, and the clinical judgment comes first. And the symptoms and signs of high specificity are bruising and myopathy. In fact, it's things involving catabolism, protein breakdown, not the more simple diabetes, hypertension, obesity, depression, because it's the catabolic effects that most indicate Cushing's syndrome. And that will include osteoporosis, which is uncommon in an otherwise obese patient. And in children, you have this extra marker, although it's rather rare in children, but you have growth failure. So an obese child who's failing to grow may well have an endocrine disorder. Just to say right at the very start, I emphasize clinical judgment. Always take a very careful drug history. There are all sorts of steroids that patients can lay their hands on, inhaled, topical, skin whiteners, intra-articular injections can last for months to years. And just to show you how we can all be caught out, this was a patient who was presented to me with Cushing's syndrome. In fact, he was first seen by his general practitioner, and looking on the internet, he decided this must be Cushing's syndrome. The GP measured his cortisol and it was undetectable. So clearly got concerned and gave him hydrocortisone treatment. So when he came to see me, he was markedly Cushingoid, and you will see his cortisol was undetectable at baseline, but after a large dose of depo-synacthin, it rose up almost within the normal range. Now, this patient had been on inhaled steroids for asthma. In fact, he had very mild asthma, inhaled steroids were stopped, his extrahydrocortisone was stopped, and he reverted to normal. So a careful history, particularly things like asthma, which are very potent steroids, and anything can be absorbed. In terms of screening, I still find the most useful test is the overnight dexamethasone test. It's very easy to do, it's relatively safe, it can be done as an outpatient, and in a patient in whom you've got a low threshold for thinking it's Cushing's syndrome, it can very quickly exclude the diagnosis. This is quite an old Chinese paper. Many other papers have said much the same. If the cortisol with 1 milligram at midnight goes to less than 50, you have pretty well excluded Cushing's syndrome. The problem is it's 80% specific, so about 20% of normal people will also fail to suppress. But if your patient does suppress, then I think you pretty well exclude the diagnosis very easily and simply. If you want to go on to a slightly more complex test, you have the 48-hour dexamethasone suppression test, which I do sometimes when I've got a much higher index of suspicion. This involves 0.5 milligrams dexamethasone 6 hourly, and then you take a blood test at 24 and 48 hours at 9 a.m. And if they're both undetectable, again, you have pretty well excluded the diagnosis. Now, when we want to confirm the diagnosis, once we had the dexamethasone test or there's still uncertainty, probably the ideal way is actually to admit the patient and look for a loss of the circadian rhythm, which is absolutely characteristic of Cushing's syndrome. Again, this is quite old data from John Newell Price when he worked with me, and you'll see that all of the normal controls had cortisol levels at midnight of less than 50. Every patient with Cushing of any etiology had readily detectable values. But of course, it's a rather inconvenient test. The patient actually needs to be in hospital, and we use it only when there's considerable uncertainty. For that reason, a lot of people have gone onto salivary cortisol. Now, this clearly just measures the free cortisol in blood passed into the urine. It's very easy to collect. The patient can do it at home on an ambulatory basis and bring it back into your lab. This is one of the earlier studies from the NIH, and it shows quite clearly in these very obvious patients with Cushing's syndrome that the midnight cortisol, salivary cortisol, is high as opposed to those with obesity, in which it's low. And that's compared with a urinary free cortisol in this particular study. Now, the problem is that although it's got good sensitivity and specificity, there's a high degree of inconsistency between the various studies. And that's because the assays vary, and you really have to have your own normative values in order to be able to substantiate the diagnosis. So just hold me a moment. I've got a noisy dog. Hold on. Right. That's one of the problems of working from home. Right, dog's sorted. So if you've got a good salivary cortisol assay and you've got good normative values, then it's quite a useful way, particularly for children, pregnant women, and people on any drugs that might interfere, for example, with dexamethasone. A word about urinary free cortisol. For many years, this has been the standard that people have used, but the problem is it's quite difficult to collect. The patient has to be highly reliable. And I just point out this study, which showed that multiple collections of the UFC were persistently abnormal in this patient, ultimately proven to have Cushing's disease. So if the urine-free cortisol is repeatedly normal, it's unlikely but not impossible. But to really be diagnostic, it has to be at least 3 or 4 times the upper end of normal. And I only now use this rarely. So what are the lessons I'd just like to impart at this stage is that obviously, when the patient walks in with gross Cushing syndrome, they're not taking any drugs, the diagnosis actually is not very difficult. However, we increasingly see quite mild cases. The diagnostic tests have not really been designed for these. And also, do not start messing around with differential diagnosis until you're sure of the diagnosis, as some people do. Equally, do not rely on imaging until you've made a biochemical diagnosis. So I would suggest you use the overnight dexamethasone test to screen. If you have got urinary-free cortisol, it's useful only when it's extremely high, 3 or 4 times normal. So to recapitulate, overnight dexamethasone is a good screening test. The low-dose dexamethasone 2-day test and midnight cortisol are ones that we tend to use to confirm the diagnosis. And the midnight salivary cortisol may be good, but you have to be able to rely on your local assays. And the urinary-free cortisol can be useful if A, it's repeatedly normal, that makes it unlikely but not impossible, or if it's extremely high, then you're home and dry. At that point, when you have the diagnosis, you can then go on to looking at plasma ACTH. Because remember, about 80% of all Cushing syndrome, endogenous Cushing syndrome, is ACTH dependent, the great majority of which are pituitary dependent, but a small percentage, 10–15%, are ectopic ACTH. So here is a patient. This is a young lady who was actually about 3 months postpartum, became psychotic, was seen in a mental hospital, and a very alert psychiatric registrar realized that this lady has Cushing syndrome. This is the sort of difficult patient one comes across. She had ACTH dependent Cushing syndrome. And in this case, as in many cases, we went on to bilateral simultaneous petrosal sinus sampling. In this situation, catheters are passed peripherally into the petrosal sinuses, and you take samples from each side, and that directly bathes the pituitary. And you compare that level with a peripheral level. And if there's a very high ratio of central to peripheral, then it's Cushing's disease, pituitary dependent. And if it's not, then you have to start hunting around for an ectopic source. And you can also use the interpetrosal gradient to see whether it's more likely to be left or right-sided. So again, this is our own early data from Bart's looking at the ACTH ratio after stimulation with CRH, centrally and peripherally. And you can see the ratio is always high, almost always high with Cushing's disease. And with ectopic ACTH, it's almost always low. And if you don't have access to CRH, probably desmopressin, 10 micrograms, is almost equally effective and very cheap. A few words then on ectopic ACTH. It's not as uncommon as we used to think. 2 big series from Bart's and from the NIH in Washington suggested that the great majority were intrathoracic bronchial carcinoids. You occasionally get other sites like medullary thyroid carcinoma, occasionally pheochromocytomas or pancreatic tumors, and about 10–20% you actually do not obviously find the source. And that's important because clearly you still need to cure the Cushing's, even if you haven't got an obvious source. And the source can be very small. For example, here you might be hard pressed to say what's abnormal. In fact, the neuroendocrine tumor, the bronchial carcinoid, was shown here. How do you find them? Well, first of all, we tend to rely on petrosal sinus sampling just to exclude a pituitary source. And then we use high resolution CT scanning. And usually it will have become apparent. With modern imaging, particularly the CT, often MR is rather less useful. And again, just be aware, some may never be found. But here is an example of a sort of patient. I think it has been useful. This is a lady who presented. She was relatively young. You'll see the central obesity. You'll see her stree and the myopathy, the very thin arms and legs, quite unusual in somebody with simple obesity. And you'll see the ready bruising. Her blood tests showed a cortisol of 2003 nanomoles per liter. Now this, I think, is critical. This cortisol is so high that she has Cushing's syndrome. She does not need now detailed biochemical tests. This is Cushing's syndrome. She has hypokalemia. She is mildly diabetic. She has slightly high white cells, as you often see in patients with early onset Cushing's syndrome. And when we measured her ACTH, it was high. So it's quite clear, the young lady, ACTH-dependent Cushing's syndrome, the question is it pituitary or is it ectopic? Well, in this particular case, it was helpful to do an indium octreotide scan because with this radionuclide imaging, the somatostatin analog sticks to many ectopic tumors. And you will see here, in various views, she had a subcarinal lymph node that was positive. That allowed us to undertake bronchoscopy. We got an endoscopic cytology, which confirmed a neuroendocrine tumor, obviously from some sort of bronchial tumor, a bronchial carcinoid, and she was cured by a VATS lobectomy. Nowadays, we actually use gallium-68 dotatate PET scanning. This is just another patient where you will see we clearly delineated metastases from a neuroendocrine tumor. And you can superimpose the images with the CT scan. So diagnosis, differential diagnosis, start with clinical symptoms and signs. Use the dexamethasone and midnight cortisol or salivary cortisol to confirm the symptom. Then you can measure ACTH. If the ACTH is more than 20, it's pituitary ectopic, start hunting, maybe perform bilateral inferior petrosal sinus sampling. If it's less than 10 persistently, it's adrenal in origin. Unfortunately, there is a slightly gray area in between. We may need extra tests in order to identify whether it's adrenal or pituitary at this stage. Well, when you're thinking about an adrenal source, I bring up this particular syndrome. Obviously, you're looking for an adenoma or a carcinoma, and they're the most common. But very occasionally, you may see bilaterally enlarged adrenals causing Cushing's syndrome. What is this? This is bilateral macronodular hyperplasia. It's not a very common disorder, or one I think one needs to be aware of. So when you have ACTH-independent Cushing's syndrome and undetectable ACTH, but both adrenals are enlarged, you may have BMAH. Some of these patients are very interesting, having cortisol responses to things like food or posture, or only having higher cortisol levels during pregnancy, because these abnormal tumors, tumor-like substances, have normal receptors. And we now know that in many cases, probably about 50%, there is identified a germline mutation of this particular gene. And then it tends to run in families, and we and others have reported families with this disorder. Something just to bear in mind. So I'll show you how we use this type of diagnostic approach in a difficult situation. I'll run through it fairly quickly. Some of you may have seen this patient before. He was a 26-year-old male. He came from the Caribbean, and we were told he was previously extremely well, very bright young man, but he had this 5-year history suggestive of Cushing's syndrome. More recently, he had proximal myopathy, fatigue, stree, easy bruising, poor libido, and peripheral edema, and fungal infections, which they often get, and secondary diabetes. And the only other information we had when he arrived was this slightly abnormal pituitary scan. Now, originally he'd been starting a variety of medications to control his hypokalemia, hypertension, diabetes, and semi-psychotic state. When he came to Bart's, he had all the clinical symptoms and signs of Cushing's syndrome, including 4 stable vertebral crush fractures secondary to his osteoporosis. I would just emphasize that the very first thing we did was his baseline electrolytes showing hypokalemia. He had a very high cortisol, over 1800 nanomoles per liter, and he had a very high ACTH. So I think essentially, and this we confirmed, that this man had ACTH-dependent Cushing syndrome. No more dynamic tests were needed. Question is, what do we do now? Well, first of all, I'd like to emphasize you control the metabolic state. The hypokalemia with a variety of drugs, hypertension, diabetes, his psychotic episodes, and his bone pain and problems. And clearly these patients are high risk of getting metabolically out of control, running into sepsis, and even dying while you're investigating them. So metabolic control is absolutely critical. And treat this as vigorously as possible. Look for sepsis, and increasingly we're aware that they have coagulopathies. But the question is then, it's ACTH dependent. Is this ectopic? Well, it's very severe. It's a man, he's hypokalemic. But Cushing's disease, much more common. So which of the two could this be? Well, the initial investigation showed on his CT imaging that he had bilateral macronodular, bilateral adrenal hyperplasia. That simply suggests a very severe syndrome. But in addition, he had this area at the bottom of his left lung of apparent collapse consolidation. We thought, was this a tumor? Well, isotope scanning didn't really help. And when he had bronchoscopy, although it showed infection, there were no malignant cells, so we were no better off. So then indeed, we proceeded, as I explained before, to petrosal sinus sampling, see, was this pituitary or was this actually an ectopic that we hadn't identified as yet? And in fact, what we found was a very high central to peripheral gradient of 5, and even a left to right gradient. So what we were seeing indeed was central Cushing's syndrome, ACTH dependent. This was Cushing's disease. And on the basis of that, we prepared him by lowering his cortisol levels. We gave him hydrocortisone when he was completely blocked. The surgeon removed his pituitary tumor, incidentally, on the left, not on the right where the scan had shown it. And subsequent to that, his cortisol was undetectable and he's cured. So I think this emphasizes a number of important points. 1, get hold of metabolic control. 2, very high cortisol and high ACTH. You don't need any further testing other than petrosal sinus sampling to identify the source. But even then, as I'll show you in a moment, there's still a significant chance of recurrence. So the take-home messages I like to say, high cortisol, detectable ACTH, ACTH-dependent Cushing syndrome, treat them vigorously. I think increasingly we anticoagulate and we look for sepsis. Petrosal sinus sampling is the gold standard when you have high levels of ACTH. Very briefly, just a few words on treatment. The treatment of choice, even in 2021, is surgery. And the ideal is, first of all, locate a really good surgeon. And secondly, aim for an undetectable postoperative cortisol. Now, we've been doing this for 20 years or more, but here's a recent paper actually in Press in JCM confirming that an undetectable cortisol after operation is what you need to aim for if you're looking for cure. If you then have persisting disease, you can go for a second operation, or you have the possibilities of various types of radiotherapy or adrenalectomy. But just to remind you that even if you are cured with very strict cure rates, there's still a chance of recurrence. And this is probably around 10 to 15%. And this means that all patients need follow-up for life. So if the patient does persist or recurs, Well, you can go, as I said, for repeat surgery. You can use radiotherapy, or I think maybe underused, still consider bilateral adrenalectomy. This is a German meta-analysis looking at laparoscopic adrenalectomy in patients with Cushing's syndrome. You see, the median stay wasn't 5 days. In some centers, as in parts of Germany, it's only 24, 48 hours. And at least this way, you can cure the patient of their Cushing's syndrome. I'm seeing a patient, in fact, tomorrow, who has an ectopic source. It's metastatic. She's undergoing treatment, but the pancreatic tumor is making ACTH. And I think it's now time for her to have bilateral adrenalectomy to at least cure her Cushing's syndrome. What are the problems? Well, as I said, it is rapid and efficient and safe. You are going to be on cortisol and fludrocortisone for life. And a lot of the discussion, I think you can see if you're interested in Nelson syndrome, is in this recent consensus review we've put out, which is currently in press. But Nelson syndrome probably less common than we used to think. A few words on medical therapy. Why use it? Well, sometimes the patient is so sick that when you've got metabolic control, you still want to lower the cortisol levels. Maybe they're so sick, but you want to operate, but you still want to make them safe for surgery. Or you've gone for radiotherapy or radiosurgery, and that may take 1 to 2 years to be effective, sometimes longer. So you'll need interim therapy. And I'll just say a few words on the types of treatment we have available and show how they work. This broadly shows the types of treatment available. You can aim for a very proximal part of the steroid pathway. Ketoconazole works quite high up. A number of drugs block the final enzymes involved in cortisol synthesis, or rarely useful, a drug that blocks a glucocorticoid receptor. We've had most experience with metirapone. It's rapid in onset within hours. It maintains its effect. You do get a bit of shunting of precursors, so ideally not for long-term use. But when we did a big retrospective study in the UK, we looked at the control using metirapone, and in about 80 to 90%, we got reasonable or perfect control. So if it's available, it was very useful. Other people have tended to use ketoconazole. It works more proximally, so you don't get high androgens. It does have hepatotoxicity, although this is relatively rare, but it works in about 50% of patients, so it's really quite useful. And sometimes you can use it in combination with metirapone, so the two drugs work synergistically. But just finally, and I think we'll come across this later on in the case study you're going to hear, ETOMIDATE. This, like metirapone, also blocks the final stage of enzyme synthesis, but it works parenterally. So you can put up an intravenous line, start infusing it. It should be readily available, and cortisol falls within hours. For example, here's a young girl. Here she is at the age of 12. By 13, she's quite clearly Cushingoid. She came to us with very high levels of cortisol, and she was so psychotic, she could not take any oral therapy. We infused ETOMIDATE, the cortisol crashed down. She became septic, so we allowed her to run higher levels of cortisol. After a month, we could put her on ketoconazole and then subject her to bilateral adrenalectomy. And it essentially saved her life with life-saving treatment that was immediately effective. Needs to be supervised carefully, but it's really very useful. So here's a young lady before and after treatment with her bilateral adrenalectomy, and we've given some of the details in a review we published 8 or 9 years ago. So just to summarize adrenal therapy, metirapone, very good. There are other new drugs that may replace it, like osiladrostat. Ketoconazole is a good choice, does not virilize. You can combine them, and ETOMIDATE is really useful when you want very fast lowering of cortisol and the patient is in the sick state. And in the last 2 minutes, just to say, well, you say, well, should I be screening my patients? Should I be screening my obese patients, my depressed patients? People have most looked at diabetes. Should you be screening all type 2 diabetes for Cushing syndrome? Well, a Danish group did a meta-analysis of all the studies, and they found really in the end about 1% they diagnosed with Cushing syndrome, but they weren't happy with these studies. So in Aarhus in Denmark, they carried out their own very careful analysis. Let's move on. And they looked at 384 patients, 60 years of age. Some of them were dexamethasone screening positive, as you'd expect, in about 22%, as I mentioned at the beginning. In a small group who did indeed have hypercortisolism, they really couldn't differentiate them from the general group. And in particular, there was no Cushingoid phenotype. And the ones they did identify had small adrenal tumors, which may or may not be important to have removed. So the conclusions is that non-targeted screening in type 2 diabetes is not a fruitful way of looking for these patients. The small one group you find really just incidentalomas and probably not important. And all I would really say, and I would recapitulate, is that you simply need to be aware of the Cushingoid phenotype. And if you see that, that's the way to progress and not use any other screening paradigm. And it can be extremely satisfactory to treat. Here is my original patient you saw before. We found an ectopic source. She had a lobectomy for a bronchial carcinoid and was dramatically improved just 6 months later and remains cured. So that's a lot of information. Thank you very much for listening to me today. I think we're going to go into a case study that's local, and eventually I'll be happy to answer any questions. Thank you very much indeed.
Thank you very much, Professor Grossman, for that very comprehensive overview of the Cushing's syndrome. And the plan now for the next 15 to 20 minutes would be the audience can send their questions to through the Zoom link, and then I'll go through the questions and put that to the speaker. But we will start off with a case with a local flavor. To do that, I will invite Dr. Chintana Dematapitiya, the Senior Registrar in Endocrinology at the National Hospital. So you might, this is our idea is to discuss, the pros and cons of all the tests that you have shown, and then what's available in Sri Lanka and what is not, and what we can do here is the idea of presenting this case and get your opinion, and then it's open to the audience as well to comment and ask you questions. Sure. So please send in your questions. Then after presenting this brief case, we'll be going on to the question and answer session. Let me invite Dr. Chintana Dematapitiya to quickly go through the current case of Cushing's disease that we are having at the National Hospital, to go through the details with you.
Thank you, sir, for that kind introduction, and thank you, Professor Grossman, for that excellent lecture. I am Dr. Chintana Dematapitiya. I'm a Senior Registrar in Endocrinology at National Hospital, Sri Lanka. So I'll move on with our patient. He presented to us with the typical features of Cushing syndrome. So beginning with the history. My slides are not moving. Right. History: 24-year-old male, recently diagnosed to have diabetes and hypertension, both poorly controlled, and presented to us with recent onset weight gain of 10 kilograms within 6 months. And further history revealed evidence of proximal muscle weakness and recurrent fungal infections and recent onset pigmentation as well. He was not on any steroid and mentally stable, and he's a teetotal. These are the pictures we took from him. As you all can see, he's having typical cushingoid face, and I don't know whether you all can appreciate, there is easy bruising, and in the nails there are fungal infection, and hands typically showing evidence of pigmentation as well. The third picture, you can see typical Cushing's stripe with purplish stripe with 1 centimeter wide stripe. And moving on, examination, BMI 32 and blood pressure was 170/90. There was no evidence of lung masses or any consolidation. Neurological examination revealed evidence of proximal myopathy, but there were no visual field defect. Investigations, HbA1c of he had a HbA1c of 10.2, AST 60, ALT was elevated for 140. Ultrasound scan revealed grade 2 fatty liver, and hepatitis screening was negative. In serum potassium was 2.3 millimoles per liter, and APG revealed metabolic alkalosis. So we further go ahead and did other anterior pituitary function tests. TSH and T4 were both normal. Prolactin was in normal range. FSH and LH both were in normal range, and as well as serum testosterone. So moving on, overnight dexamethasone suppression test was 762. It was not suppressed, and low dose DST was also not suppressed. ACTH level was 263 picograms per milliliter. These are the MRI imaging of our patient. It revealed left-sided pituitary microadenoma of 0.8 centimeter by 1 centimeter. I don't know whether you all can appreciate the tumor is here, left-sided tumor. Then high-dose dexamethasone suppression test was suppressed more than 50%. We did overnight high-dose 8 milligram dexamethasone suppression test in this patient. Then we did IPSS. IPSS revealed first prolactin central to peripheral ratio of more than 1.8. So both right and left, that means the cannulation was accurate. Then the central to peripheral ACTH ratio. Right side it was more than, right side it was 2.7, and left side it was 35.2. Then left side to right side ratio was 12.5. Just a little bit of about the management. First we try to control the comorbidities. Diabetic, we started mixed-start insulin, and hypertension, we started antihypertensives, and we corrected hypokalemia with IV potassium chloride. And then perioperative medical management, we have to start patient on IV ETOMIDATE infusion, because since he had elevated liver function, we couldn't start ketoconazole. Anyway, ketoconazole is not available right now at the country, so we are starting fluconazole. Fluconazole also we couldn't start because of the elevated liver function. Since we don't have other drugs, as mentioned, methylpropone and midodrine, they are not available at the country. We started this patient on IV ETOMIDATE. But unfortunately, while this patient was on IV ETOMIDATE, he developed left-sided lower limb deep venous thrombosis with bilateral pulmonary embolism, which we started enoxaparin. Currently, patient is awaiting transsphenoidal surgery. So that's quite a brief summary about our patient.
Okay. Thank you very much, Chintana, for that. Let me go through any comments from Professor Grossman on this case. I noticed that you never mentioned about the high dose. dexamethasone
No, okay.
supplementation. It may be old school, but I can explain why we did the high dose. Because
Okay.
it was a male, young guy with a relatively high level of ACTH, 263, and hypokalemia as well, which we sometimes, in your case also ironically, that was there. But the Bando, the general Cushing's disease with a microadenoma, we usually don't see that much of a aggressive disease. So that's the reason we.
Sure. Okay. Well, I left out the comparison of low and high dose because this is more for general physicians. But since you brought up the subject, I think it's an interesting point. You're quite correct that in the majority of Cushing's disease patients, they suppress by more than 50% on high dose, and the majority of ectopics do not. But we found some years ago that I noticed you did the low dose test and you gave the values, and that fell by more than 20%. And we found that if your serum cortisol 9am falls by more than 20% on the low dose, which you're doing anyway, then that's almost as good as looking for the high dose. And the high dose is quite risky. Someone's got Cushing's, you're giving them a lot more steroids. So I've essentially abandoned the high dose nowadays and look at the fall following the low dose. But I take your point. We also do a CRH test, which I know is also not generally available.
That's the point. Yes.
But I also point out that following the loss of a patient when I was in Oxford, who died after his transsphenoidal surgery, we looked into the coagulopathy in more detail, and I anticoagulate with heparin every patient who is diagnosed with Cushing syndrome nowadays. And we hadn't realized how dangerous this was. And if you go back to literature, not everybody does that, but I think it's become very useful. And the third point is that, interestingly, my colleague in France, Antoine Tabarin, has been looking at liver function tests of ketoconazole, and he says, even if you do have slightly abnormal liver function tests, as you do here because of hepatic steatosis, that's still reasonable to try ketoconazole or fluconazole, so long as you keep an eye on them. So very minor changes of approach, but overall, I would completely gone along with everything that you did.
Okay, thank you very much. So let's get on to the questions from the online audience. The first question that I have received, Professor Grossman, is from Dr. Sivadarshya Padmanathan. Of course, she is our colleague at the National Hospital, consultant endocrinologist. She's querying the place of ETOMIDATE in severe Cushing's disease, Cushing syndrome, I think, which you explained with your cases as well. And should we bring down the cortisol level in all patients preoperatively?
That's
a high level. She's querying our approach of reducing the levels pre-op. What is your comment?
That's a very good question. There was a recent discussion in the end of the summer of the Pituitary Society asking how many people did pre-treat. And in fact, it's a minority of us. So unless it's very severe Cushing's, or the patient is going to have to wait for several months before surgery, most of us do not pre-treat our Cushing's disease patients. So the only thing I would do, if they're very severe ectopic, for example, I might do, but otherwise do not pre-treat. It doesn't seem to be necessary other than in very severe cases.
Okay. So the next question is from another attendee. I can't see his or her name. How do you differentiate pseudo-Cushing's from Cushing's? I think that's a very valid question. And unfortunately, some of the tests are not available in Sri Lanka, but it's a very difficult position.
It's a very good question. And the answer is sometimes it's a really difficult subject. As I pointed out right at the beginning, all of the tests, all the textbooks talk about your barn door Cushing's. They walk in, you're pretty certain that's what it is. All the tests fall in line. The problem is, if somebody looks sort of Cushing or you're not sure, and the tests are a little bit positive, or the urinary free cortisol is slightly elevated, I think that's a really difficult point. And I think those of us who see a lot of Cushing's or have done in our careers So first of all, it is difficult, you know. I usually end up with a slide saying, if you think you understand and know how to deal with Cushing's, you know, see a few more, and then you realize how little we know. But in those cases, I would do several biochemical tests, including midnight cortisol, salivary cortisol where possible, urinary free cortisol. And if I'm really not certain, I would simply watch the patient and do everything again in 3 or 4 months' time. I think you have to accept a degree of humility that there are some patients, it is extremely difficult. And all of our best diagnostic tests don't always get us all the way there. And in the end, and I've written about this, it's not an algorithm, you know, do A, then B, then C. Oh, I got the diagnosis, aren't I clever? It's often probabilistic. Well, it looks very likely that, and what is the risk of an operation as opposed to not operating? So I'm afraid that's a very vague answer, but she's quite correct that sometimes it's very difficult. I do recall a patient, again, when I was at Bart's, and we couldn't work out what was going on. Was it Cushing's? Was it pseudo Cushing's? And then one day, for reasons that remain unclear, somebody did a blood alcohol level, which was massive, and the patient was on the ward. And we realized this was alcoholic pseudo Cushing's. But our best diagnostic test until that point had not revealed a diagnosis. So have some humility, do a variety of different tests, come and then finally work out what is in the best interest of the patient, to operate even when you're not certain, or to simply observe and maybe treat comorbidities.
What about these CRH sometimes would be useful in a difficult...
Yes, again, I haven't emphasized CRH because I know
because we don't have it.
Yeah. There's CRH and desmopressin. There are a lot of dynamic tests that could help. I use CRH because we have it readily available. We were the first to use it many years ago. And a really excessive cortisol response takes you home and dry to Cushing's disease. Some people use desmopressin because in normal subjects you get very little or no response, whereas in Cushing's syndrome you get a very good response. Again, what I would caution you is that don't simply take values from textbooks, because every assay is a little bit different. The quality controls are a bit different. If you're going to use a CRH or DDAVP test, I'm afraid you're going to have to work out your own normative values, and that clearly is difficult.
Yeah, thank you very much. So let's move on to the next question. Dr. Gayani Samarasinghe has asked, okay, so it's regarding our patient. Was the patient on DVT prophylaxis at the time of developing embolism? Chintana, can you answer that, please?
No, sir. This patient was not on DVT prophylaxis. We have not given. We have actually suggested, but we have not started DVT prophylaxis.
Because we'll have to convince our surgeons sometimes. They are a bit afraid even post-op for our, immediate post-op anticoagulation as well.
I understand that. We've discussed that with our own pituitary surgeon. Well, first of all, good pituitary surgeons nowadays, I think, feel that it's a relatively straightforward bloodless procedure. And we just stopped the anticoagulation 24 hours before the operation and started again 24, 48 hours later. But there is this risk of DVTs and PEs, and I have lost at least one patient who was not anticoagulated. So it is a risk.
Yeah. So the same doctor is again asking Dr. Gayani Samarasinghe a second question. Do you consider pre-op medical treatment in all adrenal Cushing syndrome patients?
No, as I've said before, well, for pituitaries, we do not. For adrenals, it depends on the severity. Again, for most of the adrenal Cushing's, unless it's gross, we go straight to operation. And once we've made the diagnosis, the operation is usually the following week or the week after that. So there's usually no delay. The surgeon is forewarned, and it would just delay things and make life a little bit more difficult. But we do have, we do have it available. We do have metarpone, we do have ketoconazole. And I, like you, I do tend to use ETOMIDATE when I want rapid results very quickly and then get on with an operation. But I haven't needed to use it very often.
Okay. And the next question is from Dr. Darshini Karupaya. Again, she's a consultant endocrinologist working in Batticalow. She's asking you whether an acute illness can raise the cortisol levels to above 1000 nanomoles.
Yes, that's a very interesting point as well. The answer is yes, but it depends on the illness. If you look at patients in intensive care, their usual cortisol levels are around about 900 nanomoles per liter, but they can go to massively high levels, 1,000, 2,000. And for example, we did a study years ago. We're looking at patients with community-acquired pneumonia, and their cortisol on admission was a very good indicator of whether they were likely to survive. The higher the cortisol, the more sick they were, the more likely they were to die. So yes, you can get massively high levels of cortisol with any septic illness, and you cannot diagnose Cushing's syndrome in the same way as you can't diagnose a pheochromocytoma with a patient who is acutely and severely unwell. So in that situation, I think you have to make your best guess and wait until they're better.
Okay. So I think there is another attendee, I can't see the name. If a patient has a ACTH dependent Cushing's with a pituitary tumor of 8 millimeters, is IPSS still indicated? I think she's asking
Okay.
about
So,
our patient and why we went ahead with the IPSS.
That's a good point. Okay, again, these details I try to hold off for general physicians, but my approach is as follows. If a patient, we do a low dose dexamethasone test and do a CRH test, and if the cortisol falls on the low dose test by more than 20%, and they show a very good response to CRH, and they have a lesion in the pituitary of 6 millimeters or more, then that's probably safe to go ahead without BIPSS. If they have a macroadenoma of the pituitary, then automatically they will not need a BIPSS because they're going to need an operation anyway. So the bottom line is we keep the BIPSS for difficult cases, but there's one caveat. You may think it's slightly unfair. The most successful radiologists are ones who are doing these very regularly. So in a sense, doing a BIPSS on most patients means that when you have a really difficult patient, the radiologist is going to have the experience. If you're only doing 2 a year, then you're unlikely to get the experience. So it really finally comes down to, if you're looking at Cushing's syndrome, it really should be in a major center that has the radiology, the interventional radiology, the pituitary surgeon, as well as, of course, the endocrinologist with a relevant experience. So yes, there are situations where BIPSS can be excluded, but we do it on a patient-by-patient basis.
So
let me explain the reason for this, because we didn't have the CRH test.
Sure.
Yeah, and of course the low dose, the suppression was there and the 20% fall, but it was a bit unusual being a male and the high levels of ACTH. So that's the reason we went ahead.
I completely agree. No, I think in your case, I would absolutely have gone ahead, because again, you have to put everything into the mix. It's not an algorithm. You've got a male, you've got very high ACTH levels, you've got hypokalemia, which is relatively uncommon in Cushing's disease. I think it was absolutely the right thing to do, even showing that lesion.
Yes. Okay, so there is another question, a lot of interest on etomidate. If a patient gets septic while on etomidate, what would be should be the cortisol target to maintain?
Yeah, well, that's sort of how long is a piece of string. We tend to go for something like 800 nanomoles per liter, depending on the degree of sepsis. I didn't actually explain it to you, but the first patient I showed you, the young man, he became, I left out the fact that we started him on metyrapone, then he went into virtually a septic state, had a fit, had a cardiac arrest, was taken to ITU, and we identified cytomegalovirus, various bacteria, and various fungi from his blood. So apart from treating him with broad spectrum everything, we also gave him intravenous ETOMIDATE and aimed for a cortisol in a septic patient of 600 to 800 nanomoles per liter. Fortunately, I think because he was young and fit, he finally came out of it. But you're quite right. You have to take into account what level of cortisol would you want in somebody who didn't have Cushing's syndrome, who was septic. It's a judgment call.
Yes, thank you very much. So the last question, again from our colleague, Dr. Sivadarshya Padmanathan. If post-op cortisol is not suggestive of cure, so uncured Cushing's after surgery, when would you go for a second surgery, or for how long would you wait?
No, that's a very good point. I think if the cortisol had fallen significantly, there is a case to be made for waiting for a week or so just to see how low it goes. I think even if the cortisol is not undetectable, if it's a 150, 200 nanomoles per liter, a lot of those patients will remain in remission. So I would not do anything. There is also, which makes life very difficult, a small group who appear to have high levels of cortisol that only goes down at 4 weeks. That's only about 5%. In general, if the cortisol is high and remains high, then it's best to operate within this 7 to 10 days, because then no fibrous or granulation tissue has formed and it's easiest for the surgeon to go in. But that really needs a very close discussion with your surgeon, because the surgeon will sometimes say, well, I looked where you told me it was and I didn't see it, so I came out. And that's a good case for going back in again within a week or so. If the surgeon said, look, I looked really hard and I looked everywhere I could and I couldn't see it, then it will be difficult to justify that. Yeah. But there may be patients, for example, a menopausal woman in whom you say, look, go in and take out the whole pituitary and go in the following week. And that sounds totally reasonable.
Okay. Thank you very much, Professor Grossman. We had a lovely evening, refreshing ourselves, and I'm sure all the participants gained immensely from this discussion and your very comprehensive lecture. In the absence of any more questions, and the time given for us is also almost up, 1 hour. It went off perfectly, a beautiful evening. Tomorrow is a holiday, by the way, in Sri Lanka, so I'm sure.
Oh, lucky you.
Mind that.
Have a good time.
And so on behalf of the Ceylon College of Physicians and the Sri Lanka College of Endocrinologists, it's my pleasure to thank you for joining us this evening, and hopefully we should be able to see you in person in the near future, hopefully, if things settle. And let me thank all the participants, the physicians and the general physicians and the general practitioners and the endocrinologists who joined us today for this interesting session. Thank you very much. And thank you, Chintana, for that case presentation. And thank you very much for the organizers and the technical team and the sponsors of this meeting, SERL, for doing the organizing. Thank you very much, everybody. Have a good night.
Thanks, Manilka. Bye-bye, everybody.
Bye.